Hello and welcome to Insight Ophthalmology. This is Dr. Amrit welcoming you to another lecture. Today we are going to discuss about a very important topic and also the most requested one, and that is the retinal detachment. In this video, we shall be talking about the various concepts which are related to retinal detachment as well. Before we proceed, I would highly recommend that you watch our previous videos on the layers of retina, retinal tears and holes, and retinal topography. Understanding these videos in detail will make your understanding of retinal detachment even more easier. In our video on the layers of retina, we discussed about the 10 layers of retina. The outer layer is known as the retinal pigment epithelium, whereas the inner 9 layers together are referred to as the neurosensory retina. The question is, what exactly is retinal detachment? Basically, whenever there is separation of the neurosensory retina from the retinal pigment epithelium, that is referred to as the retinal detachment. This you can make out on this OCT image. The outermost layer or the 10th layer over here that you can see is hyperreflective, and that is the retinal pigment epithelium. The inner 9 layers are referred to as the neurosensory retina. The separation between the two, as you can be seen in this OCT, is referred to as the retinal detachment. If you're not aware about the 10 layers of retina and how they look on OCT, I highly recommend this video on macular anatomy on OCT. Apart from that, we have about 23 videos on OCT in our playlist named as OCT by Dr. Amrit. Now, the link to all these important videos are going to be provided in the description box. Next is, how do we basically classify these retinal detachments? Clinically and etiologically, that means based on the basic mechanism which leads to these retinal detachments, we can classify retinal detachments into three types. We have the Rhegmatogenous retinal detachment, in which basically you have these retinal breaks which leads to the retinal detachment. Then we have a second mechanism which involves these proliferating membranes growing on the surface of the retina. So these membranes can be just fibrous membranes, or they can be actually fibrovascular membranes. That means they have not just the fibrous component but also the vascular components, and is usually associated with conditions which are associated with ischemia of the retina. And as we have discussed previously in a variety of our videos, that whenever there's ischemia in the retina, what's going to happen is that there will be neovascular growth on the surface of retina, and this neovascularization usually has this fibrous component associated with it. And when this fibrous component is going to contract, these membranes can basically pull on the neurosensory retina, separating it, pulling it above the retinal pigment epithelium, leading to detachment. So such detachment is known as a tractional retinal detachment. All right. Now, this tractional retinal detachment is usually seen in cases of diabetes, and it is also seen in sickle cell patients, and there are actually a lot of causes which are associated with the tractional retinal detachment. The third cause of retinal detachment could be because of accumulation of subretinal fluid due to some inflammatory cause, or sometimes even exudation of fluid from a mass lesion or some neoplasm that is sitting on top of the retinal pigment epithelium, right? So whenever there's a mass that is sitting on the retinal pigment epithelium, that is going to actually, interfere with the functioning of the RPE. Now, one of the important functions of the retinal pigment epithelium is to basically pump out any extra fluid that accumulates in the subretinal space. The subretinal space is basically a space between the neurosensory retina and the retinal pigment epithelium. Now, a properly functioning retinal pigment epithelium basically prevents the accumulation of fluid within the subretinal space. However, whenever there's excessive inflammation going on, or when there's a mass that is sitting on the RPE in the subretinal space, or some choroidal mass sometimes, it can actually cause interference with the RPE function, leading to accumulation of fluid. And the fluid in this case is known as the exudative fluid or exudates, and therefore this sort of retinal detachment, because of those exudates accumulating within the subretinal space, is known as exudative retinal detachment, right? So again, there are a variety of reasons as to why you can get exudative retinal detachment, but broadly you can have inflammations, neoplasms, and also sometimes drug toxicities. All right. Now, for the purpose of this video, we shall be discussing in detail about the Rhegmatogenous retinal detachment. Alright, so Rhegmatogenous retinal detachment is usually associated with a retinal break. Now, a retinal break could be a hole or it could be a tear in the retina. Now, what are the risk factors for development of this rhegmatogenous retinal detachment? Age is definitely a risk factor. Usually 40 to 60 years of age is when we see this rhegmatogenous retinal detachments developing. The male to female ratio is 3 to 2. As you can see, there's not much difference within the sexes. Myopia is definitely a leading cause, with aphakia and pseudophakia also acting as risk factors. Retinal degenerations, trauma can lead to retinal detachments, and posterior vitreous detachment, also known as PVD, is associated with retinal detachment in about 10% of the cases. Now, we already have a lot of videos on retinal degenerations and where we discussed about the important degenerations that can actually lead to retinal detachments. So these were the red lattice degeneration, snail track degeneration, white without pressure, degenerative retinoschisis, and cystic retinal tufts, right? So all these things, all these peripheral retinal degenerations can lead to the development of the rhegmatogenous retinal detachment. Now, we shall be focusing on this component, and that is the posterior vitreous detachment. All right. Now, before we proceed, you should know what are the various types of retinal breaks. So, we have atrophic retinal holes, we have operculated retinal holes, we have horseshoe shaped tears and flap tears, giant retinal tears, and giant retinal dialysis. Now, the ones that I've marked over here in yellow colors are the ones which can basically lead to retinal detachment or the rhegmatogenous retinal detachment. Now, the risk of developing a rhegmatogenous retinal detachment with atrophic retinal holes or operculated retinal holes is very, very less, right? Now, another important point is that if you want to know more about these type of tests, and I would obviously recommend you that you actually know about them before proceeding with this lecture. So you have to watch the video on retinal breaks and retinal holes, and the link is going to be given in the description box, right? So in that video we have talked about in detail regarding this horseshoe shaped tests, giant retinal tests, and giant retinal dialysis. Now, let us try to understand the pathogenesis of rhegmatogenous retinal detachment in detail, right? Now, over here, the myopic patients and the patients who have aphakia or pseudophakia, they are the ones who are at greater risk of development of this rhegmatogenous retinal detachment. And this happens because of two important processes which are going on in the vitreous, and those are vitreous syneresis and the posterior vitreous detachment. Now, what exactly is meant by posterior vitreous detachment? A posterior vitreous detachment, also known as a PVD, is defined as the separation of the posterior hyaloid face from the neurosensory retina. Now, if you do not know what exactly is posterior hyaloid face, you can actually visit our video on the anatomy of vitreous, right? Now, at birth, what happens is that the vitreous gel, which fills the back of the eye, normally has this jello like consistency. But as one ages, the vitreous cavity or the vitreous gel now starts getting to liquefy or undergoes a process known as syneresis, right? Now, in this syneresis, what happens is that the vitreous undergoes liquefaction, and there will be development of these pockets of fluid within the vitreous cavity, which are known as the lacunae. All right. Now, because of these pockets of fluid in the vitreous cavity, it gives the patient a sensation of some floaters or cobwebs in his field of vision, and this important symptom is referred to as the floaters. Now, gradually, the vitreous pockets will start collapsing, and as they start to collapse, the vitreous will fall off on top of each other, or it starts getting condensed, and it starts separating from the retina, and at some points it will cause this localized traction or pull on the retina, and as the vitreous pulls on the retina, the patient is going to experience something known as the flashes of light, right? And this flashes of light symptom is also referred to as the photopsias, right? Now, we know that the vitreous has started to separate from the neurosensory retina, and that is known as the posterior vitreous detachment. So let us take this opportunity to actually understand the various stages of a PVD or a posterior vitreous detachment. So stage 1 is when there is perifoveal vitreous detachment with residual vitreofoveal adhesion. It means that The vitreous has separated from around the fovea, but it is still attached at the fovea. Stage 2 is when there is perifoveal vitreous detachment with persistent attachment to the optic disc but without vitreofoveal adhesion. It means that the vitreous has nicely separated off not just perifoveally but also at the foveal region, but it is still attached to the rest of the retina and also at the disc. Stage 3 is near complete posterior vitreous detachment with the vitreous being adhered to the retina only near the disc, right? This is known as vitreopapillary adhesion. And when the vitreous starts to separate, when the vitreous has completed its separation, even from the disc or even from the optic nerve, that is referred to as a complete posterior vitreous detachment. All right. Okay, so basically what exactly is happening over here is that initially the vitreous was liquefied and it started to develop this syneresic process, and in after this syneresis what has happened is, you can see in the early liquefaction we have these pockets now starts to merge together forming larger pockets, and then these pockets starts to collapse leading to vitreous collapse, and therefore vitreous starts to separate from the neurosensory retina. Initially you have a partial vitreous detachment and following which we basically have a complete posterior vitreous detachment, right? Now this process of posterior vitreous detachment usually occurs in one eye at a time, but it can start to develop in the contralateral eye as well, and often it occurs 6 to 24 months later, right? Now this happens quite earlier in cases of myopia, and therefore high myopia is a high risk factor for rhegmatogenous retinal detachment. I will tell you how PVD basically leads to a rhegmatogenous retinal detachment. So again, summarizing the stages, stage 1 is when you have just the perifoveal vitreous detachment. Stage 2 is the foveal vitreous detachment has also occurred. Stage 3 is near complete or near total PVD with only vitreopapillary adhesion. And stage 4 is complete posterior vitreous detachment, right? And how do you identify complete posterior vitreous detachment clinically? The complete PVD can actually be confirmed clinically with the observation of this ring that you see over here. Okay, and this ring, which is seen on fundoscopic examination, is known as the Weiss ring or the Weiss ring, right? Now, this ring is nothing but here what happens is that around the disc, usually you have this dense vitreous adhesion, and as the posterior vitreous detachment completes, it also separates from the optic disc, and as it separates in the form of a ring, and that ring that you see anterior to the disc floating freely is known as the Weiss ring. So, right, so we talked about how myopia is a risk factor, because in myopia you have elongation of the eyeball and earlier vitreous degeneration and earlier vitreous syneresis, leading to an earlier posterior vitreous detachment. Similarly, patients who have undergone surgeries, whether it is retinal surgery or cataract surgery, it has been seen that they have vitreous degeneration and they develop an earlier posterior vitreous detachment, right? So basically all this can lead to a retinal break, and then that retinal break basically can allow the fluid to enter from the vitreous cavity into the subretinal space, leading to the development of RD, right? So as you can see in this OCT here, this is your retina, this is your vitreous, and you can see the vitreous has separated from the retina almost entirely except at the disc location, right? So what did I tell you initially in the video on retinal tears and holes? That we can have a lot of variety in the retinal breaks. So we have holes and we have tears, and these locations, so there are some places in the retina where you have dense vitreoretinal adhesions, right? So when the vitreous starts separating from the retina, it becomes quite difficult for the vitreous to separate from those areas of the dense vitreoretinal adhesions, right? So in these areas, as the vitreous basically tries to separate forcefully, it also takes along with itself some part of the retina, leading to the development of this retinal break, right? And eventually what will happen is that as the break develops, we know that the vitreous is now no more in the gel like consistency, instead it is more liquefied. So this liquefied vitreous can now enter through this break and go into the subretinal space somewhere here between the RP and the neurosensory retina, leading to the development of retinal detachment. Okay, so as you can see over here, you have this large horseshoe shaped tear. What is going to happen? The fluid is going to enter into this break, into this tear, and through this tear it is going to reach the subretinal space and accumulate within the subretinal space, leading to the retinal detachment. Okay, so if you want to know more about the retinal tears and holes, you can actually see the video that I'm going to provide this link in the description box. Okay, now as the subretinal fluid basically starts accumulating, it tends to follow the gravity and it gravitates downward. Okay, so the final shape and the position of the retinal detachment will be determined by the location of the retinal break. So whether the location of the break is superiorly or it is inferiorly. Okay, so you can actually estimate the position of the break just by looking at the shape of the retinal detachment, right? And there are certain set of rules which are known as the link of rules, which basically helps the examiner to find out where exactly is the location of these retinal breaks, right? So if you want to know more about that, again, we already have a video on link of rules also on the channel, so the link will be provided in the description box. Moving on, let's talk about the symptoms and the signs of retinal detachment. Often there can be some prodromal symptoms before the development of retinal detachment. So as I told you, patients can usually have these dark spots which are known as floaters in their field of vision. They can have photopsias, which are sensations or the flashes of light, and these are basically occurring because of the irritation of the retina by the pull of the vitreous as it is trying to separate from the retina, right, in the posterior vitreous detachment, right? So floaters and flashes could be these prodromal symptoms. We have a video on floaters and flashes as well in detail. Okay, what about the symptoms? The patient usually is going to complain of this localized relative loss of field of vision. Okay, so in a retinal detachment, usually the loss of field of vision is relative compared to the retinoschisis, where you basically see a absolute loss of field of vision or an absolute scotoma. Okay, so the type of scotoma that you see in the early stages of RD is a relative scotoma. Okay, now, if the patient has a superior RD, usually the field defect will be inferior. If the patient has an inferior RD, the field defect will be superior. If the patient has a temporal RD, the field defect will be nasal. And if the patient has a nasal RD, the field defect will be opposite, that is temporal. Okay, as you can see in this image, the RD over here is superior temporal, and therefore the field defect in this case would be inferior nasal field defect. So that is very important point. Now, often these patients are going to complain of a sudden painless loss of vision. That is, most of the time, these patients are going to complain that they have this sudden appearance of a dark cloud or a veil or a curtain like structure in front of their eye, right? So it's basically a sudden loss of vision. The patient is not going to feel any pain also associated with this vision. So it's trivia time. Let us ask you one question. What are the other causes of sudden painless loss of vision? So one cause is definitely your retinal detachment. So if you know the answer, give the answer in the comment box. What are the other causes of sudden painless loss of vision? All right. So now let us talk about the signs of retinal detachment. So when the patient comes to you, he comes to you with certain sets of complaints like the floaters and flashes, right? So those are known as the symptoms of retinal detachment. Whereas the findings that we elicit on our examination, those are known as the signs of retinal detachment. So usually on the external examination, the eyes will usually look normal. However, this can differ in a case of trauma. We know that trauma can actually lead to giant retinal dialysis and giant retinal tears, which we have discussed in our previous video on the retinal breaks, right? So in those cases of trauma, you are going to find some external signs which can also point towards trauma. The intraocular pressure usually is on the lower side and there will be hypotonia in the patient with RD, and this hypotonia is usually reversible. That means after the RD gets resolved or after the RD gets treated, usually the intraocular pressure also comes back to normal. Another important sign that you see is the presence of relative afferent pupillary defect or the Marcus gun pupil. We already know that, for example, in this case, if the left eye actually has the retinal detachment, what happens is that on your swinging flashlight test, when you shine the torchlight on the right hand side or on the right eye, there will be bilateral constriction of the pupil. However, when you bring the light back onto the left eye, you will see that instead of constricting, the pupil is going to start dilating, right? So that is known as the Marcus Gunn pupil or the relative afferent pupillary defect, wherein the affected pupil will basically fail to constrict in the presence of the light, right? Now this we have discussed in detail in our video on relative afferent pupillary defect, and the link is going to be given in the description box. Apart from that, on your plane mirror examination or distant direct ophthalmoscopy is nothing but you stand with your direct ophthalmoscope or retinoscope for that matter at arm's distance from the patient, and from there you're going to observe the pupillary reflex, right? Make sure at this point that the patient's pupil are actually dilated. Now, in a normal eye, this is how the reflex is going to look like, right? You will actually see a bright red reflex. However, if there is something in the pupillary area, right, which is obstructing that red reflex from coming, like a retinal detachment, or sometimes the same thing you can also see in case of a cataract, right? Where you have this opacification of the lens, which basically obstructs the light rays from coming out from the retina, right? Similarly, in case of retinal detachment, also you are going to have an altered red reflex, or instead you are going to see a grayish reflex in the quadrant of detached retina. For example, over here in this picture, you can see that the reflex is not entirely reddish in color. You see this dark area and you see this reddish area. That means there is something which is obstructing the reflex in this part. Now that could be anything. That could be something on the cornea, that could be something, in the anterior chamber, in the lens, in the vitreous, or even in the retina. So what I mean to say is one of the signs that you can elicit is the altered red reflex sign in case of your retinal detachment. Another sign that we can elicit in a case of retinal detachment is the Schafer sign. Now, Schafer sign basically refers to the presence of pigment in the anterior vitreous cavity. So you can see these brown structures over here, brown fine particles. So these, since they are so fine, it's also referred to as tobacco dusting. And this basically happens during a PVD. As the PVD occurs, the vitreous forcefully tugs on the retina and the retinal break occurs. And when the retinal break occurs, it also causes a shearing force on the retinal pigment epithelium, leading to dislodgement of some of the pigment into the vitreous cavity, right? So this is known as Schafer's sign. Now, many studies actually suggest this Schafer's sign to be pathognomic for the presence of a retinal break, and assuming that the patient has not gone any previous ocular surgery. So usually whenever the patient undergoes ocular surgery, in most of these surgeries, usually you will have some sort of pigment release either from the iris or from the retinal pigment epithelium. Now, considering that there is no ocular surgery that the patient has undergone, and if you find such pigments in the anterior vitreous cavity, then it should actually act as a warning signal, and you have to think about the retinal breaks, and you have to actually carry out proper indirect ophthalmoscopy of the patient in order to localize those breaks, right? And it has been observed that in the presence of these pigmented granules in the anterior vitreous, the likelihood of associated retinal tear is about 52 times higher than in the cases where there is no Schafer sign which is present, right? So Schafer sign can actually be considered to be pathognomic for the presence of a retinal tear. Now, how are you going to examine these patients? Obviously, for the identification of the breaks which are located way more anteriorly, you need to have wide field imaging, right? Or you can carry out your normal indirect ophthalmoscopy with scleral indentation. We know that in order to detect the giant retinal tears, dialysis, and even horseshoe shaped tears and holes, lattices, they might be located really close to the ora serrata, quite anteriorly, and therefore scleral indentation is a very important tool for examination of retinal detachment cases. Now, it's very important to understand the difference between a fresh retinal detachment versus an old retinal detachment. In case of fresh retinal detachment, you are going to see this grayish reflex instead of the normal pink color. And the retina is going to be lifted anteriorly or raised anteriorly, as you can see over here in this picture. Also, the retina would be thrown into folds, and this is known as undulations. This retina is actually going to oscillate with the movement of the eye. the retinal vessel will appear dark red tortuous cords, which will actually be oscillating along with the movement of the eyeball. So you can see these vessels over here, and you can see this ballooning of the fresh retinal detachment, right? So a fresh retinal detachment is going to appear like this balloon like configuration. This is known as a bullous retinal detachment, and as you can see, it actually has this undulation. It moves with the eye movement, and typically you will have these bright sheen at the summit. So you can see this bright sheen at the summit and grayish appearance at the depressions of those undulations. All right, now this is basically a case of acute retinal detachment, right? So normally you're not going to find any fibrovascular proliferations in a case of acute Rhegmatogenous retinal detachment, but once the retinal detachment becomes old, there can be proliferation on the surface of the retina, below the retina, in the vitreous, and also at the back of the lens. And that is basically a complication known as proliferative vitreoretinopathy. So we'll talk about that in a while. All right. Now, sometimes this bullous retinal detachment can actually extend so much that it can actually completely obscure the view of your optic disc as well. The next one is the old retinal detachment. So, how do you actually identify an old retinal detachment? An old retinal detachment is usually associated with thinning of the retina, and also there will be atrophy. So, you're not going to see that bullous appearance of an acute Rhegmatogenous retinal detachment. Moreover, an old retinal detachment is going to have these subretinal demarcation lines or the high water marks like this. Okay, these occur because of the proliferation of RP cells at the junction of detached or attached retina. Now, although at this area of watermarks you have this chorioretinal adhesion, but still it has been seen that even in chronic RD cases, the fluid can actually extend way beyond these watermarks, right? Apart from that, very old RD cases will have secondary intraretinal cyst formation as well. Right now, in some cases, when the media is quite hazy because of the presence of cataract, and sometimes the retinal detachment might also be associated with shearing of the vessels leading to vitreous hemorrhage. In those cases, it becomes difficult basically to identify the presence of retinal detachment using your indirect ophthalmoscopy. Now, in those cases, you can go ahead and do an ultrasonography. So, ultrasonography or a B scan can actually help you to confirm the diagnosis. We also have numerous videos on ultrasonography on the channel where we talk about this. This one video, we talk about how to differentiate between PVD, RD, and choroidal detachment. Also, we have a playlist and starting right from the basics of B scan to the advanced topics on B scan. All right. So, what could possibly go wrong in a case of RD which is left untreated? So, RD is definitely something that deserves treatment. And if a patient with RD, specifically the RD when it becomes long standing and old RD, the various complications can arise, and one of it is proliferative vitreoretinopathy. Now, in proliferative vitreoretinopathy, basically what happens is that new proliferations can start to develop. These proliferations can be fibrous or vascular, and mostly they are fibrovascular proliferations. They can start to grow along the inner surface, outer surface of the retina, along the vitreous cavity, and also at the posterior surface of the lens, right? Now, this scar tissue can actually exert traction on the retina, as I already discussed with you in detail before when I was talking about the tractional retinal detachment. So, similar to that, any fibrovascular tissue, and similarly here, the proliferative vitreoretinopathy tissue also can cause traction on the retina and result in the recurrence of retinal detachment surgery in these cases. So, proliferative vitreoretinopathy is definitely a complication arising out of chronic retinal detachment, but also it actually leads to poor prognosis of retinal attachment after the surgery, right? Because the tissue can cause traction. So, even if you carry out surgery and after surgery there's attached retina, the tissue can still cause some sort of traction on the retina, leading to retinal redetachment, right? So, this leads to disappointing visual results because of this. Now, for the sake of completion, let's talk about the various classification of PVR. So we have this Retina Society updated classification of PVR in which you have these three grades, basically grade A, grade B, and grade C. Grade C is further divided into CP and CA. So CP means the area of the retina posterior to equator is affected by PVR, and CA means that the area of retina anterior to the equator is affected by the PVR. Okay, and these numbers 1 to 12 basically indicates the clock hours which are affected. Okay, so if you take the entire retina and divide it into 12 clock hours, so based on how many clock hours are affected, you can actually give this grading as 1 to 12 number. Okay, so in grade A, you will see just vitreous haze, vitreous pigment clumps, and mostly they are seen in the inferior retina. In the grade B, there will be affection of the retina, but only on the inner retinal surface. Okay, so you will see wrinkling of the inner retinal surface. The retina will become stiff, but still the mobility of the vitreous is going to be present. There might be decreased mobility, but the retina is not, you really don't have those fixed retinal folds that you see in case of grade C PVR. Okay, the vessels might be tortuous, and the edges of your tears will have rolled edges, right? So the tears or the breaks are going to have these rolled or irregular edges. So that is your grade B PVR. In grade C, the thickness or the PVR is going to actually affect the entire thickness of the retina, and therefore it will actually lead to formation of this full thickness retinal folds or subretinal stands, right? So that is your grade C PVR. So over here you can see in the first picture you have the slight wrinkling. Okay, it basically means that only the inner retina is effective, and this is known as, this is actually an example of grade B PVR. And in the second picture you can see these folds basically like that of a napkin or like star shape. Okay, so this is basically an example of grade 3 PVR, in which basically the full thickness retina is actually affected by that fibrosis, right? So all these tissues which are growing can actually pull the retina anteriorly like this, and as it pulls the retina starts folding on itself, leading to formation of a funnel, right? So as you can see over here, almost the entire retina can't be seen. You can just see some hazy view here, and this is the detached part, detached part, detached part, and this is also the detached part, right? So that is happening because of the posterior vitreous, proliferative vitreoretinopathy. Now, a funnel could be an open funnel or a closed funnel. So, if the retina is closed posteriorly, but anteriorly you still see some space between the retina, that is known as an open funnel RD. Okay, and in the second picture on the B scan, you can see the retina has been reduced to this, strand, or you can say a T-shaped structure that is referred to as a closed funnel RD. Closed funnel RD means that the retina has folded on itself not just posteriorly but also anteriorly. Now, long-standing retinal detachment without any treatment, and even those which are treated and have not resolved well, they can actually land up into developing complicated cataracts. Okay, and obviously the lens metabolism is going to get affected because the vitreous and retina basically has a lot of things going on in them in the case of retinal detachment, right? Apart from that, there can be persistent inflammation leading to long-standing uveitis, and ultimately the eyeball is going to land up into an end stage, and that is known as phthisis bulbi. So phthisis bulbi is described as a shrunken, collapsed, non-functional eye, as you can see in this picture. So those are the complications of an RD which is not treated well or has poor prognosis, or a long-standing RD, right? So in the next video, we shall be talking about the principles and treatments of the retinal detachment, right? So I hope you found this video useful. If you did, kindly hit that like button, and also don't forget to subscribe to our channel. Also don't forget to check out all the important links to the important videos that are going to be provided in the description box. That's all for today. Thank you and have a nice day.